Thank you for joining us. On behalf of STS, please accept our condolences for those affected by this week's tragic crash and loss of life in Western India. I would like to welcome everyone to the STS 2025 webinar series. Today's webinar is titled STS/ISTS ISTST/IACTS webinar, Complex Airway Surgery. Please note, this webinar is being recorded and will be available on the STS website and STS YouTube channel. At this time, I'm pleased to introduce Dr. Madhuri Rao. Welcome. Let me turn it over to you.
Thank you, Karen. Before we start today, we would like to acknowledge the loss of lives in the tragic plane crash that happened a couple of days ago. And we would like to, for everyone to observe a few moments of silence. So we're all going to put ourselves on mute here for about 30 seconds. So, good morning and good evening to everyone, and welcome. My name is Madhuri Rao, and I'm a thoracic surgeon at the University of Minnesota. And my role with the STS is that I co-lead the STS task force for the STS South Asia collaboration with Dr. Dinesh Sathanantham. And it's a great honor for me today to introduce this first thoracic webinar as part of the STS South Asia collaboration with the ISTS and the IACTS. So this is the second in a line of webinar series that will be held quarterly to address topics of interest in cardiothoracic surgery to the host nations of India and other South Asian countries. So we had a cardiac one in November, and we're going to continue to do this in the coming years. And it's first venture in the line of many different collaborations to come. So with that, I want to acknowledge the leads from ISTS, Dr. Rajan and Dr. Ramasamy, who have set this up. And thank you to the IACTS for their support, Dr. Devguru, Dr. Manoj, who have helped with this collaboration, and all the guests that we have from the IACTS and the ISTS, Dr. Babatosh, Dr. Devguru, Dr. Sri Krishna, Dr. James Raj, and everyone here. So thank you all. And thank you so much for the support from the STS as well. And with that, I'm going to basically see if Dr. Dinesh, if you have a few words to add to this, and then we'll go on to the introductions.
Hello all. Good evening and good morning to the US people. This has been a great one. Collaboration has been going really well, and I'm happy to be on the second part of a webinar series and the first of thoracic. The last one was really fascinating with the more than 650 viewers on spot. So I'm hoping this would be really great enough, and I'm hopeful for a more better more important and more better collaborations in the future. And without wasting much time, I just like to go on with the webinar, and I like to Dr. Rao to take over and continue with this, and hopefully for a great webinar series. Thank you all.
Thank you, Dinesh. I would like for Dr. Rafael Andrade. He is also a thoracic surgeon at the University of Minnesota, and he is the vice chair for the STS Workforce on International Education. If you could kindly say a few words to introduce this.
Thank you, Dr. Rao. I think this is a great beginning to our interactions between the STS and the ISTS and IACTS. As you know, this is a new initiative that was just started last year, and Drs. Rao and Sadanantham had really promoted it. It's growing very quickly. We're very happy about it, and we hope to be able to develop this over the coming years to a very strong task force with great academic exchange. Thank you, everyone, for joining us today.
Thank you, Dr. Andrade. Dr. Rajan, would you kindly say a few words from the ISTS perspective, and then I will introduce both you and Dr. Gangadharan as moderators.
Good day and greetings to all who have turned in. I've been the past president and secretary of IACTS. My primary interest has been general thoracic surgery because of my late father, Dr. Madaram Santosham, who was a TB surgeon. I've attended most of the meetings of the ISTS since its inception in 1993 and a Japanese meeting of the Japanese chest surgery. During the early days, most of our students in cardiothoracic surgery were interested in cardiac surgery because of the name, fame, and money. Slowly, things started changing even in India. Cardiologists started doing most of the interventions. At the same time, newer things came up in thoracic surgery, like VATS, RATS, and airway surgery. At this point, we realized the need for a separate thoracic society in India and started the Indian Society of Thoracic Surgeons in 2018 along with Dr. Babitosh Bishwas. And till date, we have had 6 annual meetings. Dr. Babitosh was responsible for starting the DNB thoracic surgery program. I'm very happy that Madhuri has initiated the thoracic surgery webinar. I have started tracheal surgery from the time of Grillo, and I'm very happy that the first webinar is on airway surgery. I'm thankful to my colleague, Dr. Ramasamy Rajendran, who has helped me very much in doing this webinar. Thank you.
Thank you, Dr. Rajan. So to formally introduce Dr. Rajan, he's mentioned a few things, but I'm sure he's been very modest with that. Dr. Rajan's actually, he's got a lot to his credit, but some of the things that really stand out in relation to this particular webinar is that he is actually the founder and first president of the Indian Society of Thoracic Surgeons. He's also held other significant leadership positions, such as the past president of the IACTS, which is the Indian Association of Cardiothoracic Surgery, and the Asian Society of Cardiovascular-Thoracic Surgery as well. He has been a great support in making this collaboration happen. And so thank you so much, and we're looking forward to more. I would now take the opportunity to introduce Dr. Sidhu Gangadharan. Dr. Gangadharan is a general thoracic surgeon and chief of the Division of Thoracic Surgery and Interventional Pulmonology at the Beth Israel Deaconess Medical Center in Boston. He's a professor of surgery at the Harvard Medical School. And his clinical and research interests are specifically in the treatment of complex airway disease. So thank you so much for joining this specific webinar. In addition, Dr. Gangadharan, in his role, in addition to being the division chief, also serves as the program director for the cardiothoracic residency, and he's also the assistant program director for the general surgery residency. He also serves on the Department of Surgery, Diversity, Equity, and Inclusion Committee. Dr. Gangadharan lives in Brooklyn, in Massachusetts, with his wife, 4 children, and 2 dogs. And he's been an active coach and board member for the town soccer club as well. So, other interests as well. And he's also a lieutenant colonel at the U.S. Army Reserve. We're very honored to have you here with us today. And at this point, I'm going to hand over the stage to our moderators. And before that, I will ask Dr. James Raj to please introduce the speakers and hand it over to the moderators. Thank you.
Greetings from the Indian Association of Cardiothoracic and Vascular Surgeons. It's indeed a pleasure to be part of this initiative of the STS. It's a pleasure to introduce my good friend, Dr. Sri Krishna. He is currently the president of the Indian Association of Thoracic Surgeons. He was the head and professor at the St. John's Medical College, Bangalore. And now he heads and is the professor and the director of the surgical training program at the Narayana Institute of Cardiac Sciences at Bangalore. He does a lot of thoracic surgery and a lot of Airway surgeries. And he's been an invited speaker in many conferences throughout the world. And I myself have had the opportunity of listening to him on a fair few occasions and have been quite impressed. He is also a DNB and an MCH examiner for the cardiovascular and thoracic course and the thoracic surgery course as well. He was the regent representing India at the European Society of Thoracic Surgeons from 2011 to 16. And he is the section editor for thoracic surgery at our national journal. And the Royal College of Edinburgh has honored him with an honorary FRCS. And he's a wonderful person as well. So who better to talk on the tracheal surgery today? Over to you, Dr. Sri Krishna.
Can I hand this to the moderators at this point? And Dr. Gangadharan, if you could kindly say a few words and get the topic started, that would be great. Thank you.
Certainly. I do want to thank the STS and the ISTS and the IACTS for the invitation, to yourself as well, Dr. Rao, for having me here. I think this is an incredibly important topic. I think there are many topics in thoracic surgery and surgery in general where understanding when to operate and when not to operate, and that very fine dividing line between those two options comes into play more than complex airway surgery. So I think the two topics, the upper trachea and the lower tracheobronchial tree, we're going to hear some very interesting talks about them today. And I encourage all of the participants in the webinar to please bring their questions into the Q&A section. We will monitor that, and at the time after both of the talks are completed, we'll have plenty of time to have the speakers answer your questions. If you put it in the chat, we also will see it, but probably not going to be monitored as well as the Q&A, so please use the Q&A.
Dr. Sri Krishna?
Yeah. Okay, good evening, and thank you very much for those kind words, Jacob. At the outset, on behalf of the Indian Society of Thoracic Surgeons and the STS Southeast Asia chapter, it gives me a great pleasure to welcome you all for this webinar on tracheal surgery. I also thank the organizers for this opportunity. Tracheal surgery started in the 1960s, and these were the pioneers at that time. To this, we must add our own Dr. Rajan Santosham, who pioneered tracheal surgery in India. Disorders of the trachea is a domain of multiple surgical specialties, and the surgical procedures on the trachea were not popular till late due to its peculiarities. Trachea is 11 centimeters long, and only about 4 to 5 centimeters can be safely excised and anastomosed comfortably, as there are no substitutes available. The blood supply is segmental and from the lateral surface, and if injured, can impair healing. The recurrent nerve also runs close and can be injured.
The indications for surgery are shown here. Post-intubation stenosis, tumors, and traumatic tears are most common. Some of the principles to be followed for a good surgical outcome is depicted in the slide. Pre-op evaluation and airway management is of utmost importance. Pre-op evaluation involves delineation of the site and extent of the lesion, distance from the vocal cords and carina, and the amount of trachea that can be safely removed. To that effect, imaging and preoperative bronchoscopy is extremely important. Among the various imaging techniques, CT and MRI play a major role. Bronchoscopy is an indispensable preoperative investigation. Post-intubation tracheal stenosis is probably the most common indication for surgery, and I'm sure you all are aware of the pathophysiology of the same. The various types of tracheal narrowing and stenosis are illustrated here. They can be intraluminal obstruction, extrinsic compression, scar or stricture, web stenosis, etc. Airway management plays a very important role. If the stenosis is less than 6 millimeters, pre-op dilatation with a gum elastic bougies, balloon dilatation, serial dilatation with rigid scopes can be done. If the stenosis is more than 6 millimeters, an uncuffed 5.5 millimeter ET tube can be passed across the stenosis under fibroscope guidance. When there is a large tumor almost occluding the lumen, some sort of debulking will be necessary. Anesthetic management includes induction and establishment of an airway and maintenance of spontaneous ventilation, which is desired. During the open tracheal phase, cross-field ventilation with an ET tube and/or a jet ventilation is employed. Spontaneous ventilation and extubation at the end of the procedure should be the goal. Recently, many centers have started non-intubated anesthesia for tracheal surgery. The advantages and difficulties are shown here. However, we have had no experience in this. Resection and end-to-end anastomosis without tension is the gold standard. The type of surgical approach depends on the site of the lesion and the type of procedure plan. Most benign strictures are accessed by a collar incision. Tumors with extratracheal involvement may require a partial sternotomy or clamshell. With the right posterolateral thoracotomy, the whole right bronchial system, the carina, and the distal trachea, as well as the left main bronchus, are accessible. The steps of cervical tracheal resection are shown here. This is a slide showing the bronchoscopic view showing a tight tracheal stenosis. On table, balloon dilatation is performed and an airway is established. A collar incision is employed. Strap muscles are exposed and the thyroid isthmus is divided. Stenotic segment is identified. Trachea is transected just distal to the stenosis and cross-field ventilation is established. Stenotic segment is excised. Posterior layer anastomosis is begun. Anterior layer is completed. This is showing the anterior layer with interrupted sutures, preferably. And the anastomosis is checked for air leak with saline. Strap muscles are reapproximated, and a chin to sternum stitch is applied at the end. This is my own modification of a sternovertebral stabilizing brace used for cervical fractures, which facilitates early mobilization day after surgery. Patients are quite comfortable with this. Slide tracheoplasty is the procedure of choice for long segment tracheal stenosis, especially in children. Our pediatric surgical colleagues have done about 23 cases over the last 10 years with good results. Airways can get injured by trauma or by instrumentation, and the approach depends on the site of injury, as already alluded to. Procedure involves a vascular muscle flap interposed between repaired trachea and the esophagus. A representative case, a 53-year-old man with a large tear in the membranous trachea who presented in a moribund condition, was successfully managed through a posterolateral thoracotomy. This is an example of a squamous cell CA of the trachea in the cervical region with good results. Follow-up 6 years later showed disease-free status and is doing well. We now come to a few special situations. Sometimes additional maneuvers may be required to gain additional length to achieve a tension-free anastomosis. One of the commonest procedures employed is the suprahyoid Montgomery release, wherein the hyoid bone has been cleared off of the muscles with exception of the digastric slings and then allowed to drop down. This is one of the commonest procedures employed. This is the Montgomery release procedure that has been already explained. For cases with subglottic stenosis, Dr. Pearson has described a procedure with an oblique anastomosis, preserving the recurrent nerve. This is a condition where there is a communication between the membranous posterior wall of the trachea and the anterior wall of the esophagus. Surgery is the definitive management. The fistula is dissected and divided. Esophagus is closed in 2 layers and a muscle pedicle is interposed. The trachea is repaired primarily or resected, and end-to-end anastomosis is performed. Stenting is generally done in patients not fit for surgery and not recommended for benign disease. Another example of a TEF repair, patient from Dubai who had an upper lobectomy in 2004, develops a TE fistula in 2018 following reactivation of TB and MRSA infection. He was repaired via a posterolateral thoracotomy, doing well in May 24 when last reviewed. Sometimes foreign bodies are culprit and many a time require an operative management. This is a life-threatening situation where there is a communication between the anterior wall of the trachea and the innominate artery, leading to exsanguination. Whitley maneuver is an emergency technique during an acute bleed in the ICU. The index finger is passed through the tracheostomy wound, compresses the innominate artery against the sternum to control bleeding. Median sternotomy and innominate artery ligation is the definitive treatment. It's a difficult operation in a disastrous setting. I've had the experience of 3 cases, 2 we salvaged and 1 we lost. Some of the recent advances include less invasive endoscopic balloon dilatations, and use of stents. Resection of the web-like stenosis with electrocautery or lasers are being done by interventional pulmonologists. Tracheal transplantation is still in the experimental stage with anecdotal cases, and maybe in a few years' time, we will have a good tracheal substitute. Post-operative management is extremely important and involves airway control, humidified oxygen, clearance of secretions, and avoidance of aspiration. Common complications include dehiscence, recurrent laryngeal nerve injury, fistulae, infection and granulation. Anastomotic stenosis generally occur late. This is my own modest experience. We have had 127 cases, majority of them being post-intubation stenosis. We have had 9 traumatic injuries and 15 tumors of the trachea. Early in the series, we did a combined cervical and thoracic approach, but as our expertise improved, we were able to manage most of the cases through the cervical route alone. Right thoracotomy approach is reserved for lesions close to the carotid. High rate of success can be anticipated with proper assessment and meticulous surgical technique. Many series have reported 90 to 93% good results. We cannot overemphasize the importance of a multidisciplinary approach for airway surgery. It involves the surgeon, the anesthetist, the radiologist, the otolaryngologist, respiratory or pulmonologist, and the supporting staff. In conclusion, upper tracheal surgery is challenging but feasible. Multidisciplinary approach is essential and it can be performed well. Thank you very much.
Thank you, Dr. Sri Krishna. Dr. James Raj, do you want to introduce the next speaker and then we can go to Q&A at the end?
Yeah, thank you, Dr. Madhuri. Our next speaker, Dr. Saravana Rajamanikam. He is a robotic thoracic surgical oncologist. He initially trained here in Chennai at the Madras Medical College. Then he went on to do his master's at the King George Medical University at Lucknow. And then he did his specialization from the Tata Memorial Institute at Bombay. He now practices at Namakkal, which is an industrial town in Tamil Nadu in South India. And he runs a minimal access thoracic surgery fellowship as well. He is a specialist in lung preservation surgery, and he's been doing a lot of it robotic assisted as well. He has done more than 1,700 of these cases and is probably one of the pioneers in this part of the world. He also chairs the robotic surgery division at the Tangam Cancer Institute at Namakkal, and he has pioneered targeted therapy, immunotherapy, and various other specialized treatments for thoracic oncology patients. Welcome, Dr. Saravana Rajamanikam. Over to you.
Thank you. Am I audible?
Yes, all good.
Am I audible? Yeah. I would like to thank, with my greatest sincerity, the opportunity given to me by Dr. Rajan Santosham. He still is a very big mentor for me. And the ISTST, the IACTS, the STS and the IACTS for this lecture. So I'll be talking after Professor Sri Krishna, and I'll focus my talk on lower tracheobronchial surgery and how in the current era we manage these problems. The indications for surgery would be tumors, stenosis, fistulae, anomalies, and then trauma. I will stick to tumors because that is where my focus lies. Traditionally, airway surgery is usually in the open fashion, with a neck incision, with a sternotomy, with a thoracotomy. But in the current era, what we have experienced is any tumor or a problem that is located below the suprasternal notch, we can provide minimal access solutions for these patients. So this is my favored approach for surgery, which is the semi-prone anterolateral approach, and it's a multiportal robotic technique. So what is actually a sleeve resection, which is the common terminology used for resection of the lower tracheobronchial airway, is when we actually resect and reconstruct a portion of the bronchus or the main airway trachea, and that is called a sleeve. And this is greatly different from just cutting the bronchus and sewing it, which is a bronchotomy, or just making a wedge resection and a closure, which is a bronchoplasty. Very important considerations have to be given to the anesthesia, because we have to always place a contralateral W tube for isolation. Non-intubated technique has come up in a great way, and I have not started performing these, but it's catching up like wildfire. In very complex cases, ECMO is of great help. The most important thing that we should learn here is there's no blocker policy in these patients. We can perform these operations open, VATS, and robotic. But believe me, most of the tracheobronchial work that I have done now, and I continue to do and propose, is actually robotic, because it makes the operation quite easy for even a novice surgeon to perform. So the standard way of doing a robotic approach would be a multiport lateral approach. But over the years, I've shifted to an anterolateral approach and then to a semi-prone approach for resecting tumors in the lower tracheobronchial tree. So this is how we dock. The robot comes from the back of the patient. Patient is in semi-prone position, and we have an assistant in front who helps us during these operations. So these are the suture choices, and this is a timeline. I started my career with Vicryl, then moved on to Prolene and PDS, and now the standard suture material that I prefer is the V-lock self-locking sutures. And the technique which I find most easy to perform using the minimal access is actually the technique that has been described in Vienna. It's a continuous technique where you start from behind and then come forward and close the suture, which has very less complication rates and less stenosis rates. So let's move on to the cases. This is the classical indication and the most easiest sleeve resection to be that you will come across. You can see most of these are done in carcinoid tumors, which are low-grade tumors where you have you can do these resections, and the margins that you require for these resections are just a negative margin. And most of these patients, you can see over here, the approach that you see is actually the semi-prone view, where the esophagus is on top and the lung falls in front of the camera, and it gives excellent view to exactly the area of business. So here we are actually cutting the bronchus intermediatus below. We've already transected the artery and the vein to the upper lobe, and you can see the tumor from within the bronchus there. Most of these tumors in the right side are close to the esophagus vein, and so we usually ligate the esophagus vein in these situations to get good exposure. There we are cutting exactly at the carinal level. In most of these operations, we also do a frozen section to confirm the negative margins. And this is the classic sleeve resection. You have two ends of the bronchus, and all you have to do is to sew them together. We have already removed the upper lobe in this patient. So what we are going to preserve in these group of patients is actually the middle and the lower lobe on the right side. So like I mentioned, the anastomosis is a continuous technique with a self-locking suture. And I usually use two sutures and the sutures both are stopped at the cartilaginous portion in the anterior aspect. At the end of the operation, you look for air leak from the main airway as well as from the parenchyma. And most of these operations, when you do without radiation, when you do upfront, don't require a flap and they heal quite well. So when do you need a lung resection? A lung resection is not absolutely required. It is required only when there is irreversible atelectasis of the lung. You can see on the left hand that the lower lobe and the middle lobe are totally atelectatic and the upper lobe is ventilated very well. And in these patients, even if you do a resection and anastomosis, the remnant lung will not expand well. So those are the situations where we would do a lung resection. And obviously when tumor is occupying the ostium of the lobe. Another area where we need lung resection is when there is segmental airway involvement. The tumor is going into the segmental airway, like it is seen on the right side. And so we have to part away with that particular lobe so that we can get a margin negative resection. What about complete parenchymal preservation? There are certain locations in the airway where you can get away without removing lung parenchyma. The proximal right main bronchus and the proximal left main bronchus are those locations where you can avoid resecting lung tissue. You can just do a sleeve resection of the bronchus here. Again, a similar view, like I mentioned, you can see the secondary carina there on the right side. And we are actually transecting now the bronchus intermedius. And now, just like the previous case, we would transect at the upper level also. But in this patient, we are actually preserving the ostium to the upper lobe. So that now what we have is two structures. The indocyanine green is useful to actually delineate vascularity of the distal bronchus. And here, because the distal part was dark in color, we resect that portion of the airway so that we can have vascular ends at the anastomosis. And now we are actually preserving the entire lung parenchyma, and we are anastomosing the right main stem with the sleeve of the right upper lobe bronchus and recreating the entire secondary carina. These patients do quite well, and because the tumors do not involve the lung parenchyma or don't involve the segmental bronchus, we need not remove any lung parenchyma in these patients. So how about proximal left main bronchus? This is a really tricky situation. When the lesion is very proximal to the carina on the left side, these operations are also done from the right side because you know it's very difficult to access under the arch of the aorta tumors from the left side. So here we are using a cross-field ventilation just like we would do open. And now during a period of apnea, we are actually reconstructing the airway, the right proximal bronchus lesion. And in between, we sometimes use jet ventilation to aerate the distal airway on the left side, or we reinsert the tube to give time for CO2 washout. You can see the esophagus is actually slung up along with the vagus to help us complete the resection. So it's very essential to have a tension-free anastomosis. And sometimes if the tension is too great, I prefer to do an interrupted suture using a Vicryl or a polydioxanone suture in this situation. Can you do a partial sleeve? So a partial sleeve is when it's almost like a bronchoplasty. Here you can see this is on the left side where we have actually on the left hand of the instrument is the superior pulmonary vein and the inferior aspect is the inferior pulmonary vein. And we are doing an anterior approach to the secondary carina. You can see this patient had a tumor exactly on the medial wall of the secondary carina, the lateral wall of the secondary carina, the posterolateral wall along with the membranous trachea were free on bronchoscopy. And in these patients, we are not doing a complete transection of the secondary carina. We're actually removing only the anterior sleeve through the anterolateral approach and reconstructing the entire airway, just doing a partial sleeve resection. All these patients who are undergoing airway surgery, we send the margins for frozen section, and we try to achieve R0 resection for all of these patients because it's essential to prevent local recurrences. Always, like always, we always do a indocyanine green to check for the vascularity of the airway before reconstruction. And then we take sutures to reconstruct this airway. What about proximal tracheal lesions? You can see over here, when there is a lesion just proximal to the carina, because of the view provided by robotic surgery, the anterolateral approach gives a fantastic view of this particular aspect of exposure to this aspect of the trachea. So traditionally, we would do a sternotomy and resect these patients and reconstruct. But here we see we are ligating the azygos to give us exposure. We've all taken a sling around the distal main trachea, and we are transecting the airway, both the distal and proximal, during a period of apnea. So in between the resection, we push the endotracheal tube distally, and while we are ventilating, we actually resect the remainder of the tumor. We bag it and send it for frozen section. And you can see that cord-like structure in between is actually the vagus. And we do a complete end-to-end anastomosis. And because we have the robot with us, it's extremely, helpful, and we can complete the anastomosis within 2 apnea cycles, where in between we ventilate the patient using the same endotracheal tube that is passed through the normal route. So this is how we are reconstructing the membranous trachea now. The best part about the robotic technique in semi-prone is the more tension is on the cartilaginous aspect of the suturing, so which is actually down, and it's posterior in the dissection plane. And you can avoid a sternotomy in most of these patients with good cosmetic outcomes. Can you do more complex work? And this is also possible. Here we are doing a carinal resection. We've already transected the airway, the carina, and we are actually anastomosing the right main bronchus using the same anterolateral approach. We are now joining the right main with the left main first. And then after completing the anastomosis of these two, you can see a cross-field ventilation through one of the ports is being used to ventilate the left lung while we are doing this. And once we finish the joining the left main bronchus and the right main bronchus, we actually connect the proximal trachea with the combination of the neo bronchi to create the neocarina. In case you have some small minor leaks, or you feel that there is tension in the anastomosis, so you can actually do the classic intercostal flap. This is also done by minimal access. You can take the intercostal muscle and then place it over the membranous part of the trachea, which most commonly, because of the has needle bite air leaks, minor ones, which usually don't require any repair, or you just put a patch. Never put a patch circumferentially around the anastomosis, because it can lead to stricture. How about mobilization in MIS? When we need much to create a tension-free anastomosis, we may need to create a good mobilization. So sometimes you can actually do this by minimal access. Here we are doing a hilar release. We are doing a complete hilar release like you see here, so that the entire lung along with the tracheobronchial tree can move up for the anastomosis. You can also do it, you can also do it via mediastinoscopy. I found this technique very essential, very useful, because you can actually free up the entire airway instead of doing an opposite thoracotomy or a VATS in some patients. How about size discrepancy? I have found that up to 30% of size discrepancy you can match by your suturing technique, by matching cartilage to cartilage. There are other advanced techniques which can be used to match the size discrepancy, but in general, up to a 30% discrepancy you can adjust with end-to-end suturing. What I found with experience is that preservation of the nerves while doing sleeve resection helps in the bronchial toileting post-op. And we have seen that when we prospectively identify the vagal fibers going to the remnant lung and preserve them while doing these resections, the number of times they require a bronchoscopy in the post-op period to clear airways has drastically reduced. We can also combine these complex operations like a sleeve with vascular sleeve resections, where in this patient you can see a patient with actually an atypical carcinoid which invaded into the lingular portion of the PA, and we are transecting it, and we are now anastomosing the two, after completing the airway anastomosis, we are now anastomosing the vascular anastomosis as well. So this is also, these kind of operations are also possible in minimal access. Once we complete the anastomosis, we can always check the integrity by using indocyanine and green to check whether the anastomoses are vascular. But of course, we cannot deny that open operations still are important in the current arena, especially in Indian patients, where sometimes you just can't get into the thorax because of adhesions, or very complex airways resection where you have to do multiple implantations, reverse Barclay technique, and a type of anastomosis. These kind of operations are still done via the standard open approach. We are a relatively young team, so we've completed around 64 minimal access tracheobronchial resections, wide variety, most of which are right upper lobe sleeves. We've done tracheal resections as well and carinal resections as well, but they just form a small part of it. And of these, around 13 have been pediatric patients, and the outcomes are mentioned here. We've had 2 conversions, we've had 2 margin positive rates, and those patients went on to require adjuvant radiation. None of them have, and then I've had 1 stricture, and after having that stricture, I've found that this indocyanine green to identify the vasculature of the airway to be anastomosed is very important, so that to get a good vascular anastomotic end. And we have 1 leak which we managed with conservative management and which settled at 11 days. We have standard length of stay around 4.6 days with a good operative times. And most of these patients are very active and very functional. Because they are young, they are very optimistic about the cosmetic outcomes of these approaches. However, this is the take-home message. These operations are tough and you need to prepare for them. You need to have absolute command over anatomy. You need to know the vascularity of the ends of the airway that you're getting together. The suture technique, you must hone over time, whatever you use, interrupted, continuous, whatever you prefer, you need to get it to a very standard level. A tension-free repair is important. We have excellent pre-op planning tools which help us in these operations, and post-op care with sometimes bronchoscopy, which are required in these patients, is very important. The greatest thing that I would like to mention is without the team, these kind of surgeries are not possible. The anesthetist, the pulmonologist, the rehab person, the ICU intensivist, and the ICU care nurses are very important to get these patients up and about after these operations. I would like to say that since starting the minimal access approach, I have rarely used the chin stitch that is normally used for tracheal surgery, and totally it's abandoned. And most of my patients are so happy that they've got away with that kind of a thing. Once again, I'd like to thank the STS, the ISTS, and the IACTS for giving me the opportunity to showcase my experience in lower tracheobronchial surgery.
Thank you to both of the speakers. Really amazing experience that you've relayed, and also I think illustrates the supreme need for excellent technical skills. Those operations, which both of you made look easy, are quite difficult. And if the sutures are not placed correctly, if the size is mismatched, the patients can really suffer. I'd like to ask Dr. Krishna, this has come up in the chat, and some of the questions around the tracheal release. And I think maybe we can blow that back out to a question around how do you know what is too much, meaning when would you potentially back out and say that it is unresectable, even though you thought up front it was resectable for the upper trachea? And then in addition to the Montgomery release that you described, what other adjuncts, i.e. T-tube placement or even a trach at the time of resection, might you entertain as possible solutions?
Yeah, that is a very important question. Pre-op assessment, especially nowadays when we have the 3D reconstruction of the CT and MRI, we can actually measure the amount of trachea that needs to be removed. I agree that for the upper trachea, it is usually the Montgomery release. And if we have the thoracic approach, either open or VATS and this thing, you can go around the pulmonary hilum, inferior pulmonary vein can be released, or the inferior pulmonary ligament is released. And then some people have also described use of cutting the pericardium almost at the diaphragm and getting the entire this thing up. So yes, that is important, but I think the preoperative measurement, as we always say, that it's about 4 to 5 centimeters. Anything more than that is not very comfortable to do a resection. Maybe Dr. Rajan can add on to this.
Is the amount of trachea that can be resected depends on whether it's upper trachea or lower trachea. In the upper trachea, 4 to 5 centimeters by proper planning and mobilization can be done. Another additional step we take in mobilization is a U-shaped incision on the right hilum below the inferior pulmonary vein and the hilum and release it. This gives you an additional length. And about one more comment about the neck stitch. I have had the misfortune of during my early 100 cases, there was nobody to guide me. I had to read the books and do it. That is about 30 years, 40 years ago. We had one case of quadriplegia, which improved later. So now I'm very careful to put a very loose stitch, very loose stitch, so that our lower trachea, I don't use it. Upper trachea, I use a loose stitch so that it prevents hyper extension and disaster. Thank you.
Yeah, in the present day, the chin stitch is only to prevent hyperextension rather than keeping the neck flexed.
One question, and it has been partly answered with regard to using adjuncts to cover the anastomosis, either fat pad, but I think what was shown was intercostal muscle. But the question was around whether any other agents, i.e. bioglue or some other topical solution have been used. And then maybe you can expand that answer to discuss what happens when you do see an anastomotic leak, because that's something that the trainees that are working with you are probably going to be the first people to observe some of the signs of a leak, either in the neck or in the chest. Obviously a little bit more straightforward, but could you speak to the use of bioglue or bioprosthetic like that, and whether or what is your process for evaluating the leaks when they do rarely occur?
My preference is if on bronchoscopy the rent is less than 2 or 3 millimeters, then only in that situation I would probably go in for a conservative management like a glue removal. Anything more than that would definitely require surgical correction and a reinforcement. And especially if in those cases where we often see a post pneumonectomy BPF, then in such a situation we also use the omental graft coming up from the abdomen and use it as a buttressing technique.
So in my experience regarding the use of patches, I have rarely used bioglue because of availability issues in my institution. And I always feel that native tissue is the best if you ever want to cover when you're doing the surgery. So my go-to is when we're doing the anterolateral approach, the intercostal like I showed. But then in the lateral approach, when I used to do earlier, I used to take up the thymic pad of fat or a pericardial fat to put on the most critical areas of which is the membranous trachea, which, there's a tendency to leak in those locations. With the current sutures and the techniques that we use, I don't think we will be seeing very big leaks. But of course, I understand where you're coming from. So in the neck, for the trainees, if the patient has a subcutaneous emphysema, it's the first sign that you should look into. Of course, in the thorax, you have an air leak which comes out to the intercostal drain, and you can identify those patients. I've found that the interventional pulmonology people have, short stents which are covered, which are temporary and can be removed in certain situations. I have not had for my own cases, but I've had my colleagues tell me that they've used short stents to just, when the rent is small and the leak is significantly low, to use those small stents and then remove them once after about 3 to 4 weeks. Of course, when you have a major leak, the only thing that you need to do is to get in as early as possible, do a good toileting, and then use a patch or a good material to actually reconstruct or redo the anastomosis. I think these are important points that we have to understand when we're doing these operations. Anything that you would like to add?
Has any of you had experience using hyperbaric oxygen to salvage anastomoses?
No, I have not had any experience with that.
So I'm a big proponent of I think the leaks are mostly because of too much tension at the anastomosis and a poor judgment on the vascularity of the resected ends. And that is why when we tend to mobilize, without any visual aid, we don't look at the vascular aspect of the ends of the airway. And that's why I always, because in minimal access, you have the opportunity to use the Indocyanine. I'm a big proponent because after shifting to the Indocyanine green technique, I have not had leaks which would be probably attributed to vascular issues. And the other thing I would like to mention is what do you call the videos that both me and Professor Krishna had shown. We didn't show the mobilization that is really required to get these ends together because of the brevity of the lecture. And just showing the anastomosis doesn't do justice to the work that is being done before what we do it. So I think, we should give importance to a good tension-free anastomosis. And that being said, the principles remain the same as it was in Dr. Grillo's time. The good anterior and posterior mobilization, prevent devascularization of more than 1 or 2 centimeters from the ends, get these together and make sure that they stay together. A use of a tension relieving stitch that can be used in addition to the anastomotic stitches so that it can hold sutures well. I think these are good points to take when you're performing these operations.
I'd like to just mention one thing. Absolute preoperative planning is essential. That comes only with experience. In the first 100 cases I had to learn it and do it myself. The complications were high. But the next 400 cases, the complications become less. One thing I want to stress again and again, upper trachea is different from lower trachea because lower trachea you can't pull up without cutting without doing a sliding technique like taking the right main bronchus up because of the presence of the arch of the aorta, which limits mobilization. Or you have to cut the left main bronchus and suture it to the side of the trachea. So it's completely different, upper trachea and lower trachea. Lower trachea, amount of trachea that can be resected is much smaller. And as we again stress, proper preoperative assessment and planning is essential before you undertake major tracheal surgery. Thank you.
Some really great questions. We have an extension, so nobody needs to leave at the prescribed time. We can keep going. The speakers have generated a lot of interest in the audience. I think following on the discussion around vascularity, there were a couple in the chat and the Q&A around what you would do if it looked different. And this is, I think, similar to what we see with esophageal surgery, where people use ICG and then, it's not entirely clear that resecting back to the back to the transition point in your fluorescence necessarily helps you avoid ischemia. So how reliable is that ICG fluorescence at the edge of the airway? And what do you do if it doesn't look as good and you've already resected as much as you think you could have safely?
I think that kind of a situation you never want to be in. And of course, whenever we use this, we have some margin for revision. So the question for if you have vascularity issue, you resect until it is vascular and then do the anesthesia. Of course, after having this ICG, it's hard for me to do a comparison without using it. But the other thing is, when I've had one situation where I've had to go back to the neck to do a Montgomery release to get additional tension, to get additional sliding of the trachea. So that I've had to do once, because once I revised, the tension was too great when I was trying to attempt a closure. So we had to take the patient back to supine position, do a Montgomery release, and that gave me an additional 1.5 centimeters, and we got out of that situation. I think in borderline situations, like you asked rightly, when would you not do a resection? I think 4.5 to 5 is stretching a little bit too far. And most of these, you have to be very careful when you're attempting surgery in these kind of patients.
Yeah, it seems that sometimes there's sort of the prescribed length, but then when you get in there, if there's a lot of periadventitial inflammation and you're not able to achieve the tension release despite the maneuvers, is when you might consider it. And unfortunately, there are times where understanding that can only take place after you've cut into the airway. So for me, what I try to do is, as best as possible, is once I've done all the release maneuvers, I will try to slide the airway up and down and just see how much you're gaining a centimeter here, you're gaining a centimeter with flexion, you're getting a centimeter with a release. So when you start adding those up, maybe you have enough, but it's a bad situation to be in once you've already resected and then you realize that it's going to be under tension. And in those cases, for me, rarely I will then add a T-tube to protect the anastomosis. And that way, if it does start to, dehisce, partial dehiscence, you'll still have some patency of the airway. One question that has come up several times in the discussion here is, and I think the techniques for airway management during the case were both very nicely pointed out, but there are some questions around the use of ECMO for airway surgery. If either of you could please address that.
I have used femoral bypass many years ago, when ECMO was not that popular or proficient. But after that, I've not had the use of ECMO. It was quite useful and it was fast, and we could get away with very difficult stenotic cases.
We have not had much need to do, even as Dr. Rajan said, bypass ECMO for a cervical anastomosis, but for lower thoracic anastomosis, maybe it may be required. And especially the pediatric surgeons, when they're doing a slight thoracoplasty, have been using ECMO quite considerably. So in that situation, maybe ECMO would be necessary.
I think you meant tracheoplasty, slight tracheoplasty.
Tracheoplasty, yes.
Tracheoplasty.
So I have used crossed field ventilation in the minimal access approach, either through the back and endotracheal tube or through the one of the ports along endotracheal tube to ventilate the opposite airway while doing complex tracheobronchial surgery. However, in one institution where I operate, we had the opportunity of having ECMO. And then we had a complex case in that institution, and I found that the absence of a tube when you're cutting and anastomosing the airway makes life so easy. And of course, an ECMO in my institution is we don't have ECMO in our institution. And so we try to use these alternate methods. But I believe in Europe and the United States, most of the complex lower tracheal work, when they are done by minimal access, are done using ECMO. I think Dr. Gangadharan, you may give us much more information. I've had two situations where I've used for complex lower tracheobronchial surgery, and I found it very useful because there's no tube in the system, and it's very easy to perform these operations. What is your take?
Yeah, I would agree. I think there's a level of stress that comes way down when you have ECMO. I think it can't be, I can't overstate the amount of bravery that it takes to put a transfield endotracheal tube in robotically. Because if it doesn't go in, if the airway starts to tear and fall apart, you're 10, 15 feet away from the patient with no recourse. So I think, when you show it going in and out very easily, it's pretty amazing. But I think when you have ECMO at your disposal, it does give you a level of safety that is quite comfortable.
Can I make a comment?
Please.
Do the thoracic surgeons interchange the word peripheral bypass or cardiopulmonary bypass with the ECMO, or is it same? Because for a cardiac surgeon, ECMO is totally different from a CPB. It is being interchangeably used in thoracic surgery, ECMO and CPB?
I think there is veno-venous ECMO is enough. And in the States and in the West, they have the single cannula ECMO technique. So you have within a single cannula via the IJV, you can actually use that single veno-venous cannula to perform. You need not put two cannulae in the artery and the vein as we do for any peripheral bypass. So when we use it purely for a thoracic indication, I think a veno-venous bypass, and you have these specialized cannulas which are useful for these kind of operations, which is you switch it on, you perform the surgery, and you switch it off in the post-op on the same day or the next day morning. You can take them off these things. So I think it's different when you use it for cardiac and you use it for this is purely pulmonary.
So veno-venous is veno-venous is sufficient for oxygenation alone. When the pump is working, the heart is functioning. So veno-venous is ideal for all lung surgeries.
This is what we normally use for the same thing that is used for lung, what do you say, COVID
transplant also.
For transplant, all these things. Yeah.
A question for you, Dr. Gangadharan, if I may. Have you got any experience on non-intubated tracheal surgery?
No, we haven't been doing that. Other than we do some, most of the endoscopic work that we do will be through an LMA, or a fair amount of the work, if you don't require rigid, we'll do it through an LMA. And I will often start my tracheal resection with an LMA if it's in the cervical trachea, but we don't continue the operation that way because we get the transfield tube in place typically.
I think in VATS, I think we should close. What do you
go ahead and answer. Go ahead and say what you have to say, and then we'll probably close after that. Thank you.
In VATS, because we use a thoracotomy incision, mini thoracotomy, or a wound expander, the atmospheric air is taken in by the patient when the patient is in deep IV sedation. And so most of these non-intubated for lower tracheobronchial work has been in VATS, where the patient actually breathes through the port, the wound expander that we use, wound protector that we use. Whereas in robotic, I found it difficult because the CO2 is required for you to do to have a good exposure, and the CO2 going in through a non-intubated airway, causes high CO2 narcosis, high, hypercarboxemia. So the CO2 levels go quite high, and I've stopped using because I'm more into robotics and not VATS now.
Thank you all very much for your participation. Thanks to the audience for their engagement. And thanks to ISTS, IACTS, and STS. We will close the session. I
Thank
think
you.
something. Yeah, go ahead.
Yes, great. Thank you so much to the Indian Society of Thoracic Surgeons and the Indian Association of Cardiovascular-Thoracic Surgeons for this important collaboration with STS. And thank you to our moderators and speakers and panelists for your participation and insight. We invite you to become a member of STS if you're not one already. You'll enjoy a variety of benefits and opportunities to help you grow professionally. Learn more at sts.org/membership or scan the QR code on your screen. Access convenient online courses and symposia like the 2025 annual meeting, Lung Cancer Clinical Trials Meet Clinical Practice through the STS Learning Center. Again, scan the QR code to see all the available programs and learn at your own pace. We are going to continue this wonderful collaboration in August, so keep an eye out for our next webinar date. Thank you so much again, and I hope everybody has a great day or evening. Take care. Thank you so much.
Thank you very much. Thank you very much.
Okay.
Thank you, sir. Thank you again for the opportunity. Thank you so much.
Thank you.
Thank you.
Bye-bye.